Thank you, Andrea, and thank you all once again for your time today. We're really looking forward to this presentation. And I've been in touch with Dixon and Janice off and on over the past few months, putting together the presentation today. And as you've noticed, we have a very packed agenda. And as John mentioned, Church Pension Group certainly has a lot under its roof. And we'll get into that here in a moment. From pensions, life insurance, of course, the healthcare benefits, we'll unpack that today. And Andrea mentioned that we'll sort of split the duty here. We've got, I'll lead off, and then she'll come in and pinch hit, and we'll go back and forth a little bit. If y'all have questions, I prefer the style of ask those as we go. We could do at the end if you want to hold some questions to the end. We'll be available following the presentation for one-on-one conversation if you have questions for us. One of the things we do best at Church Pension Group is communicate with one another. We are a seamless benefits organization these days. We like to say that we've de-siloized the different divisions of Church Pension Group. So if a question comes to me today and it's not in my wheelhouse, I'll make sure that that gets to the right individual back at the office, and then we'll communicate that back to you. As Dixon is familiar, we bounce a lot of questions off each other. I call his cell phone at odd hours of the morning and so on. But as Andrea mentioned, I am the single point of contact for the diocese, for the benefits administration team, to make sure that everything that the diocese needs to know from Church Pension Group can be addressed. And that's the division I'm in, as you see on the screen here, the acronym IBAMS, and we use a lot of acronyms at CPG. IBAMS is Integrated Benefits Account Management and Sales. And then the Northeast region, for the most part, account manager. The reason I say for the most part is I recently picked up the Diocese of Milwaukee, and last time I looked at a map, that's not in the Northeast. So we'll start off with a little bit of background and definition of the Church Pension Group. Of course, you all know on the surface who we are and generally what we do. This is always important. I love leading off presentations with this. Why do we exist? We exist to support the clergy and lay employees of the Episcopal Church in their calling to spread the gospel. That's something we always need to keep in mind. As I operate through this, it's a very much business-oriented operation, my day-to-day work, but always keeping our service to the church and you all in mind as we work. I also like to unpack this here. As I mentioned, we've got a lot under our roof. We operate under three primary business units. Employee benefits, that's Andrea and myself, and that's the first cog here. And then property and casualty insurance, and we have a publishing house. If we look at the timeline, we're coming up on our 100-year anniversary. 1917 is when we first started offering pensions. And then we jumped to 1918 on the publishing side. That was Church Hymnal Corporation started publishing hymnals for the church. They operate today under the name of Church Publishing Incorporated, offering a wide array of print and electronic publications and other resources for church administration. Back to the benefits side, we added life insurance in 1922, and today we still offer all these health benefits. We got into that in 1978. So as you can see, as we unpack the health benefit side today, which is probably 2/3 of our conversation, we're not going anywhere. We've made this work, and we've got lots of examples today of how we're continuing to make that work in light of climate changes in the healthcare industry, like the Affordable Care Act. We've got a lot of information to go into to show you how we're sustaining this business in today's healthcare market. This is our core values at CPG. As I mentioned, that we have a de-siloized, seamless benefits organization these days. Part of that effort was the implementation of core values. I guess you could say it's sort of an active mission statement in action. And everything that we do, professional, compassionate, and trustworthy. As I mentioned, ask us a question, we don't have the answer, you'll be able to trust that you'll get the answer to that question, or at least a response. We'll talk a little bit about the Episcopal Church Medical Trust. This is, of course, where the healthcare benefits generate from. And with the medical trust, again, the objectives are to serve the church and maintain financial sustainability. We'll get into how we're containing costs and continuously ensuring that we're the best financial stewards of the fund for which we serve. We offer the high-quality health plans. I'll touch on a few of the points here. High-quality health plans that provide robust benefits. Again, that's what a lot of what we'll be covering today. And the competitive rating and stability. We'll talk a little bit about how, of course, each year health plans undergo rate increases. How we do our best to keep that contained. Andrea's division, they're masters at the keeping these numbers in control so that we can still provide affordable benefits. This is also a slide I'd love to speak to here as we talk about cost containment, as we talk about where does the money go, how is it spent, how is your claims, your medical claims, the money that exists there, how is that utilized at the back end. And as you can see here, we've got this pie chart. 89% of each dollar goes to benefits and an additional percent to member surplus. So that's 89 cents of the dollar. Every dollar that goes into the fund goes back into benefits. Just 5% for plan administration and 5% for vendor administration fees. So again, good stewards of the fund for which we serve. Come on.
Since this is one of the areas that I work on extensively, there's a little tiny footnote on the bottom that you might not have been able to read. And that is with the Affordable Care Act, insurance companies are required to basically set this rate at 85 cents. In the small group market, it's at 80 cents. So that means that 15 or 20 cents on the dollar is going towards either overhead costs or profit. Our model is very different. In this slide, it's 89 cents. Over the last 3 years, it's averaged between 89 and 91 cents on the dollar. That means more dollar per dollar that goes in is going directly to pay for claims payment. We're not in the business to make money. We're in the business to be able to return to surplus, to take care of those unexpected or unintended things that happen in a health plan. Things like having a year where we have an excessively large number of shock claimants or large claimants that are over the $100,000 mark. So we don't want to have to be reactive and volatile. Health benefits can be a very volatile industry. And so we use our surplus really to be able to smooth out benefit increases across the years and to be less reactionary to sort of those ebbs and flows that happen. Things like specialty pharmacy, where great, brilliant drugs come out, such as the ones that treat hepatitis C in the last year. They also come with pretty hefty price tags of $85,000 per person who's on those. Now it's a cure where there never was a cure before, so that's phenomenal. But that's also something that you have to take into consideration in the cost equation. And so we really use that small, modest amount of surplus to make sure that we're providing as much towards benefits in any given year as we can.
Excellent. Thank you. Thanks, Andrea. And we have our tightrope walker. Just a quick mention here to show that how we, as I talked about, cost effectiveness and meeting your needs by delivering high quality plans, and we'll get into that momentarily. Important point here as we talk about the denominational health plan. Again, we'll use this acronym from this point forward, the DHP. Before we get into speaking about plan specifics, and I believe you all received the plan choices for 2016. They're hot off the presses and rates. Before we get into that, as the association which administers the health plan to the church, we find it important to explain the denominational health plan and how this came into play. I won't cover every detail on it. You may know some of this. But the General Convention of 2009 in Anaheim is when the Title I candidate of the Constitution and Canons was established to offer a denominational health plan across the Episcopal Church, mandated for parishes, the diocese, institutions subject to the authority of the church. That we did. The DHP guidelines, the canon guidelines, was this would be fully implemented for those groups by January 1st, 2013, And we did realize that, and we'll have some slides coming up for that as well. More details on it. The requirement, all employees that are compensated for 1,500 hours or more per year, beginning with January 1st, 2013, are to be covered under the health plan unless there's an eligible opt-out in their situation. And then each diocese would set a minimum cost-sharing policy or parity that must apply equally to eligible clergy and lay. And that will be established by the end of this year, December 31st, 2015. The original canon in 2009 was that they'd be side by side, but in 2012, Resolution B026 extended the parity requirement there. Since we have so many groups and different ways of practicing their cost sharing policies, it's taken a little extra time to get that in line. Okay, and then also mentioned here, I know the diocese has some of these voluntary institutions such as schools and other affiliated organizations. If you have a retirement home, Episcopal home, those sorts of organizations, they're welcome to participate, not mandated in most cases, and they can participate on a voluntary basis. And it's just a little bit more about the resolution B026 on the parity that I mentioned, requirement in place by December 31st that we have equal cost sharing between lay and clergy. Mentioned a moment ago that the participation, we do now have 100% of all domestic dioceses participating in the DHP. That went into effect January 1st, 2013, as expected. We have 48 additional groups. Those are the voluntary groups participating. And the big number, the DHP currently serves 26,000 members. Nice animation, Andrea. All right. Denominational health plan has two very separate and independent goals. I mentioned cost containment and parity. And we're doing our work in each of those areas. Here's how we're delivering the expected cost containment. Feasibility study on the DHP was conducted and estimated that 10% cost containment savings was fully implemented, or went into effect when the full implementation went into effect. That has since come up through 2014. That number has risen to 13% cost containment, giving a savings to the church of $69 million. I mean, we keep our eye on these numbers as well, just as we keep our eye on costs for healthcare. That savings is passed directly to you, to the church, through lower annual rate increases. Again, we do our best to try to contain the rate increases, and we'll talk about that right here. The Medical Trust average rate increases for health plans since 2010 has been between 4.3% and 6%. We compare that to the U.S. average employers' rate increases for the same period. Those rates have been those increases have been between 5% and 11% for the same period. I've been seeing some other numbers and looking at stories in the news that 13% for a lot of employers is becoming sort of an average threshold as well. So we're keeping ours. In fact, this year we kept it at 6% rate increase on the average across our offerings. At this point, I'll hand it over to Andrea to talk about healthcare reform, Affordable Care Act, implementation of the Cadillac tax coming up, and so on.
So healthcare reform. How many of you spend your days and nights reading newspaper articles about healthcare reform? A few other people who are crazy like me. So the big questions that we wanted to talk to you about today are, do the exchanges offer better coverage? I think there was a question earlier today about can groups opt out and go to the exchanges? Are the exchanges more affordable? We'll get into that a little bit. And then will we be subject to the Cadillac tax? So the answers are yes and no, yes and no, and yes and no. Dig into a little bit more detail there. So you might have started to hear words used like metal plans when it comes to describing health benefits. And really the government has set up the exchanges in a way that they felt would be a very easy correlation for folks to understand benefits richness. And what they used was a metal system. So bronze being the lowest level of plan, really meaning it's got about 60% of the benefits that the plan's paying, members paying 40%, silver at the 70% level, gold at the 80% level, and platinum at the 90% level. They also put a little squishy range in there, plus or minus 2% of those items. So when you look at where the exchange marketplace is headed, it's way over here with silver being the standard on the left-hand side. Where the medical trust is today, we are way over here on the right-hand side with platinum benefits. In fact, with 82% of our enrolled membership being in a platinum or a gold plan. According to the government and according to a lot of employers and individuals, that model is just not sustainable. But at the same time, it's also asking a lot of individuals to take on additional cost share, especially in organizations like the church where benefits historically have been exceedingly rich over there in that 90+%, sometimes 100% level, because that's what we want to provide to our members. So it's a very interesting crossroads that we're at in terms of affordability and what really is appropriate coverage to have and what's adequate coverage, and is that affordable or not. So in terms of our competitiveness, the medical trust rates are generally on average for comparable plans, and I'll speak to comparability a little bit in a second, but we're 3% below what's called the SHOP marketplace, which is the small employer marketplace, and on average, we're 2% below the individual marketplace. So how did we do that analysis? So we worked with our internal actuaries as well as our external actuaries at Aon Hewitt. We actually took every single member that we have enrolled in our plans. We looked at them, we looked at their age, we looked at their zip code, and we compared that to the exchanges to a comparable plan. The interesting part about comparability is one of the things that really has become quite prevalent with the exchange marketplace are a lot of just different people who have entered the marketplace. There's some Medicaid plans who are trying to gain some market share. There's some of the big players, the Aetnas, the Cignas, the Uniteds of the world, who are also trying to gain market share. And when you think that there's 40+ million people out there who are uninsured, this is a great opportunity for people in the marketplace. But there have been some tricks and tips and things that have happened in there as well, such as the use of narrow networks. So you get a lower rate, but it also closes down the availability of the providers who are available to you. So if in a broad national plan, there's 10,000 providers available, in a narrow network, there may only be 5,000 providers available. So how many of you are familiar with Trenton? Okay, so we've got St. Francis, we have Capital Health, I think we have St. Mary's. What happens in a narrow network is that maybe St. Francis is the only one that's considered in network, and you lose the other two hospitals as being part of your network. So that has a definite impact on people. In every community, there's not necessarily always one place that's the go-to. And so while the plans themselves on the surface, the deductibles, the out-of-pocket maximums, the co-pays, may be very similar, there's some underlying things that we need to look at in terms of comparability. All of the medical trust plans today are built off of broad national networks because we have relationships with the national carriers. We could look at these smaller, narrow networks, however, we're not right now. We really don't think, we want to see how that plays out and tests out. We think it's got a lot of opportunity for member disruption. And so some things were sort of in that wait and see or holding pattern. But overall, when we took all those rates and marked individuals to the market, to their age, to their zip code, on average, we're about 2% less. There are outliers. And for those of you who may have been at General Convention or heard about some of the conversation that took place at General Convention, there are instances where a younger clergy person or a younger lay person could go to the market and find a less expensive rate. There are certain pockets of the country where the healthcare marketplace is more competitive than we are. But across the church, overall, we are more competitive. So the Cadillac tax, how many of you heard about the Cadillac tax? Okay. This is the big looming next great thing that happens in the Affordable Care Act, and it's effective in 2018. And it's really a 40% excise tax or Cadillac tax on plans where the government considers either the cost or the richness of the benefit to be too great. One of the things that it doesn't necessarily take into consideration, and so there's a lot of debate and comment periods still going on related to the Cadillac tax, is an age adjustment. So when you look at an aggregated group, like the Episcopal Church, can anyone guess how old the average age of our employees are on the plan? You guys are great, very close, 52. Average age of our membership when we take spouses and children in, it's about 42. So we are older than the average bear or the average employer. And what comes with age? Oftentimes, a chronic disease burden. That's when we start to get sicker. That's when our health starts to fail. That's when our claims costs start to escalate. So there's some things built into the Cadillac tax that don't work for all employers across the country. So the government has been good. They have asked for comment periods. We are part of a larger church benefits association, so it's all the denominations across the country. And we come together and we group purchase health benefits, and we share best practices in health benefits, and our lawyers talk to one another, and our IT folks talk to one another, and our CEOs, and our chief investment officers, and everybody works to sort of find our commonality and see where we can affect greater good for denominations across the country. And so Cadillac tax is one of those items. So back in May, the core lawyers working group of this Church Benefits Association sent a letter to the government and said, here's all the reasons why we think the Cadillac tax doesn't work for church plans, and here's all the things that we'd like you to take into consideration as you look at the Cadillac tax. There's a second version of that that's actually being worked on to go out in the next couple of weeks. So we do have some fierce defenders on our behalf who are trying to see what we can do to either mitigate some of the impact of this. There's some folks who say, well, maybe it'll go away altogether. I'm not one of them. I think when you look at the Congressional Budget Office and you look at healthcare reform, it was a system of revenues and expenses that needed to balance out. This is a big chunk of the money that pays for things like the uninsured, like the unknown risk. So I think that it may stick around. So with that in mind, as we look at our product array strategy, as we look at our groups, we're running calculations about who may be impacted by the Cadillac tax and when. We're looking at how rich our benefits are. We're looking at alternative options in those bronze and silver ranges. We look at further group purchasing and how do we drive costs out of the system, cost containment, all those things that Jeff talked about, so that we can mitigate as much of the impact as this is possible. 40 cents on the dollar is a lot of money. So, medical plan types. This slide, we just wanted to orient you, since this is a benefits afternoon, about the different types of plan designs that we offer. PPOs are really our primary or predominant plans that we offer. Those are plans, very simply, where there's a provider network that has both, on the provider network, you have the in-network level of benefits. The plans also offer out-of-network benefits at a lesser rate, but it gives those members that flexibility if there's a specialist or someone that they want to see that's outside of the network, that they're able to see them. These plans are very free in terms of access to them. There's no gatekeeper. You don't need to have a primary care physician. You make that decision of who you want to go see, hopefully being a wise consumer of healthcare and checking out for those good cost and quality providers while you're out there. You can self-refer to specialists, and then if you see somebody in network, the claims file through the system, and if you see somebody out of network, you have the responsibility to file a paper claim. Exclusive provider options, they really are on the same essential platform of the PPO network. However, the benefits themselves are only on the network side of things. And health maintenance organizations are network only unless it's an emergency. EPOs really are the same thing. You can't only go out of network if it's an emergency. But the big distinction between our EPO plans and our HMO plans is that the Aetna HMO does have a gatekeeper on it. You do need to pick a primary care physician. You do need to check in with that person for referrals to specialists. So I think you have the sheet that got passed around of the plans and rates that are offered for the year. So one of them, the first one up, is the Cigna Open Access Plus, or the OAP plan. This slide represents what the actual benefits of that plan are. So the network deductible is $500, $1,000. Out of network is double that. The annual out-of-pocket max on this family, or on this plan, is $2,500 per individual, $5,000 per family, and the co-insurance on this plan is 20%. So if you think back to those medals, the 90, the 80, the 70, the 60, At the 80%, this is essentially a gold plan. Our plans tend to be on the rich side, so we're really a gold plus plan, bordering on a platinum plan for this particular one. So this just gives you a high level. These slides will be posted, I believe, on the website. We also, as part of your annual open enrollment, provide a plan comparison chart, which has all of the plans that the diocese offers stacked up one against another. So you can kind of look at the difference in the benefits, figure out what's right for you, what's right for your family, if you have dependents, what your needs are, what your health care, if you look back over the last year or two, you look forward to the coming year, you maybe been having a problem with a knee and need a knee surgery, and take a look at what's best for you. Also on our website, our summaries of benefits and coverage are available, as are our plan handbooks. During open enrollment, and I believe we already have them up, the 2016 schedules of benefits are up. Plan handbooks get published after the first of the year. We found that when we publish both the current year and the future year, folks sometimes pick the wrong one. So summaries of benefits coverage, plan comparison charts are up there, but the handbooks will be in January. So this just goes over in a little bit of detail so that you all have them, the components of the plan. Next up is the United Healthcare Choice Plus. Again, very rich plan. This one's a platinum plan. This is one of those plans that's on the PPO side of things. You have both opportunity for network care and non-network care. Very rich plan when there's no deductible. Good indicator of a very rich plan, no deductible, and member coinsurance is zero if you go in network. So a lot of the plans that the diocese offers are really very benefits rich. So office visits for preventive, there's no copay. For other services, it's $25. Our plans all tend to be fairly similar in terms of urgent care, emergency room, outpatient hospital. There might be some slight differences in the copays or in the coinsurance. The piece that really ultimately, if you're making your plan decision and you're thinking of it from a purely financial point of view, what's your deductible and what's your out-of-pocket maximum? Those are the two things that are really going to tell you the personal affordability of the plan for yourself when combined with the portion of the premium that you may be responsible for. So EPO plans, again with Cigna, as you have the open access plan, you also have an EPO or a network-only version of that. So why would you pick the OAP over the OAP-in? When somebody has a really strong, robust network and of doctors who are available to them, if they're not seeing specialists, it may just be easier to be in the one that has the network-only option. Folks tend to pick the PPO options when they've got a specialist that they want to see, or when they just like that safety net of, if the person I want to see isn't in network, then I've got this fallback position. Again, $0 deductible, zero coinsurance, $25 copay, a nice level of benefits on this plan. United Healthcare Choice, this is an EPO. Again, no deductible, no coinsurance, $25 copays. So you're really looking in these plans at that out-of-pocket maximum. That's the number that's really going to be important to you when you compare the plans. In addition to things like, do I like United, Aetna, or Cigna more? Who has my providers? What kind of care am I really needing over the course of the year? And then the HMO, which I think is probably your predominant plan, at least it used to be. This is the one where if you're in this plan, you are going to need to have a designated primary care physician. So for this plan, you have to do it. On the other plans, you don't have to have a primary care physician, but what I will say is that there is value in having one, and having one person who sort of understands and has their eye on the total picture of your care, make sure that there aren't any gaps in care, make sure you're being compliant, make sure that one doctor's doing isn't going to impact negatively what another doctor's doing. So there's value in having that one sort of go-to person. High deductible health plans. You guys have very little enrollment in high deductible health plans. Do you guys have any interest in high deductible health plans? Okay. Do they scare you? Okay.
And I know you can save a lot of money with a high deductible plan where you just turn around and throw that deductible as HSA, and you're still overall savings. That's something that you're being considered.
Yes. So for the question for the folks in the back of the room who may not have been able to hear, and also since this is being recorded, the question was on high deductible health plans, the premium is usually lower. direct sort of correlation to two things. One, the fact that it is such a high deductible, and two, the fact that a better health risk tends to gravitate towards high deductible health plans. That money, if you take sort of the premium offset and then contribute to the health savings account, even contributing to the health savings account, oftentimes the equation works out that it is less expensive to be in the high deductible health plan. And then you have that opportunity for the employee to either have that money in the account that can be used to offset the high deductible, depending upon what their financial situation is, or where they have those funds that can sit in the account, earn a little bit of interest, if enough are accumulated, be invested to help pay for future healthcare expenses. Our IBAMS team has got some great models that they're able to help groups with in terms of figuring out if the high deductible health plan, some of the financials behind it, if it really can work for individuals or for groups. The one thing that we have found is that the initial sort of reaction of folks who are going to launch an HDHP is to fund that deductible at 100%. I actually don't advocate for that because it's a consumer-directed plan, and I do really feel that employees always have to have some bit of skin in the game. They're going to make better choices if they think about it in terms of their money. And the reality is, churches are a very different employer than the rest of the world, as you all know. So money comes into plate and pledge. Sometimes you're lucky and you have an endowment. That money goes towards premium. We're a self-funded plan, so the way that the health benefits get used, with that 89 cents on the dollar going to pay for claims, it sort of becomes a circle. So being wise healthcare consumers, it's good for you, it's good for the plan, it's good for your employer. It's kind of good all the way around. And I think sometimes people just think that insurance is that big bad insurance company, and that the correlation of how it all fits together for a self-funded plan or for a plan like ours maybe doesn't always get translated as well as it could from an education point of view. And so the high deductible health plans really do offer an opportunity to get that consumer engagement, to look at a little bit financially different model. They also, with that, now that healthcare reform has a known annual out-of-pocket maximum, it used to be the old days, like on the Aetna HMO, that those co-pays just kept counting towards nothing. Now they actually count towards the out-of-pocket maximum. So you could conceivably be in a really rich, Aetna HMO plan prior to out-of-pocket maximums with the Affordable Care Act and spend a lot more money than somebody who's in a high deductible health plan because that cap was always there. So that safety net's been there for 10 years that we've had high deductible health plans. Now we have it on all the plans, but it really does make the case for a high deductible health plan, even for somebody who's less healthy, where the sort of old notion was that you had to be healthy to be in a high deductible health plan. I think they really do work for everybody. So let's get into the details of them. So what is a consumer-directed plan? That was a long answer to your question. Okay, so this year we actually launched 2 additional high deductible health plans, one at sort of that gold level, one at the bronze level, but what I'm going to talk to you about is our existing high deductible health plan that we launched back in 2004, and that's our $2,700 deductible, high deductible health plan. So the one caveat that I do always need to, or feel I need to make about high deductible health plans is that network and non-network benefits do not cross-accumulate. And so what that means is you go in network, you've got this level of out-of-pocket expense. You go out of network, you've got this level of out-of-pocket expense. You have to add one to the other. So it can be very cost prohibitive to go out of network on a high deductible health plan. With the traditional plans, if it does have an out-of-network benefit, everything sort of ends up in that same pool of your out-of-pocket cost. So that's my one caveat on high deductible health plans, where you really need to be a good consumer if you're going to go out of network. So the other half of the HDHP HSA equation is the health savings account. And that is a tax-advantaged account that pays for qualified medical expenses. And where's my tax friend here? Has to pay for qualified expenses. Otherwise, the government will find out. The annual funding limits right now are $3,365.50. I think it goes up maybe by like $50 a year, so we'll have new numbers for 2016 on that. The one thing that's very different about health savings account versus flexible spending accounts, in health savings accounts, the dollars belong to your member. The second that you put them in their account, they're theirs. So if you pay on January 1st for them for the year and they leave on June 30th, they're still taking that money with them. So just something to think about from the employer side or from the treasurer side or the parish payroll person as you're funding them. Keep that in mind because the money does become theirs. It essentially behaves like an IRA or 401k. The dollars can be invested once you get to sort of that minimum thresholds of the banks. And both the employer and the employee can contribute to the account in either pre or post-tax dollars. Yes?
I think one of the reasons why this isn't used more often is because your standard church treasurer is like a deer in the headlights when trying to think of how to set up an HSA. So is Dickinson's group or your group people to go to in order to facilitate?
Okay, that's a great takeaway. So the question was, setting up the HSA can be scary, so can we help with that? We can absolutely help with that. So here's how the HSA works. When you are enrolled in a medical trust health plan, the HSA comes with it. It goes with the bank that either the health plan has selected or in 2016, the bank that we've selected. We're actually going to be switching HSA administrators for 2016. The funds can come directly into the medical trust and we get those applied. So we really do have a good system. We've got a good fact sheet. We've got a good spreadsheet for you to send the funds in on. You could use your local bank if your folks are more comfortable with that. We're a little less able to help you when that's the instance, but certainly we have folks in our benefit operation that can help you. We have folks in IBAMS who can help you. We have folks at the vendor who can help you, and I'm guessing you guys can help too. Absolutely. Okay, so that's a good point.
The follow-up to that is about the tax advantage. So if the clergy person is putting some money into the HSA, does that have to go? Is that taken out of box number 1? It's deductible, but does it have to appear in box number 1? No. Okay.
So there's a pre-tax and a post-tax component to it. I don't like to give tax or legal advice, so we can certainly, Jeff, if you want to write that down, we can look at that question a little bit more in depth than you may want to as well. So I think we had one question and two questions. Yes, the question was, can you only have an HSA with us if you have a medical plan with us? It's even a little bit more strict than that. You can only have an HSA with us if you have a high deductible health plan with us. And you have to have a high deductible health plan to have an HSA with it. So the government sets certain limits of what is a qualified high deductible health plan. So, question. My understanding is that Paychex does know how to do the HSA funding to our group because we do have a lot of groups that work with Paychex and that have the HSA. And then also the benefit is within that benefit ops group, the IBO group, Integrated Benefit Operations, there are cash application and collections folks within CPG. They handle the HSA funding. So they have a very strong relationship within their team, both on the Paychex side and with the HSA administrator, so they'd be able to help you. Yes. Right. Adjustment on your income on the 1040. Okay. Couple more questions back here. Correct, yes. The health savings account is in the context of a high deductible health plan. There are also HRAs, health reimbursement accounts. We don't offer them, but you all could set them up as employers or as the diocese has. Yep, that could be set up locally. Mm-hmm. Yes. Yes, so the question was, is there investment options? There are once you get to a certain dollar amount. I believe it's either $1,000 or $2,000. Once that's accumulated, then the banks will let you invest it and not just have it be interest bearing. I think they like to set it at a certain amount because They need to see whether people are going to use those funds, because if it, then you go to the pharmacy and you swipe your card, or you have a surgery and you use your debit card, and then it falls below the amount. So they like to have it at a certain level before that kicks in, but it is an option, yes. Another question. It depends on how the employer sets up the funding. So we have everything from groups who fund it 100% at the beginning of the year. So maybe they set their HSA funding at 80%. They'll fund that whole lump sum amount in January. We have some groups who will put 50% of that amount in January and 50% in June. We have the other groups who send us money every payroll. They have it set up with their payroll vendor. It gets taken out biweekly. They send our portion, and we can fund no matter what frequency it comes in. So my point was, for those groups who maybe do that upfront funding, if that employee leaves, they get to take those funds with them. So from your own either protection or cash flow point of view, some groups, want that protection, especially first year that they move to a high deductible health plan, and that deductible really scares their employees. They want to reassure them by saying, okay, you're going to have this lump of money. We're going to put that in for you on January 2nd when the banks open, so that if anything happens, you've got funds there. But the risk there for the employer is, if they do leave, they could take it with them. So, yes?
The question came about the benefits committee last month, but if you have a health savings account and church contributes $400 a month, about $5,000 a year, you combine that with a premium or the AMP plan, it ends up being more expensive than the other plans. And so what's the advantage?
Okay. So not for all groups does the financial equation work out to be an advantage. I think the way that your all's HMO is priced, especially given the richness of the HMO, it is not, I think, maybe the best financial option for you all in the short term. In the long term, it may be, just because what we've seen is that the costs have been more containable on the high deductible health plan than maybe on some of the other plans. So that's where the IBAMS folks can really help you and do that analysis for your whole group. If your benefits committee already did it, we can just take a look at it and see if that is the case for you all. For a lot of our groups who offer, like the PPO plans, like the United Healthcare plan, if that's where your predominant enrollment is, then the high deductible could be a very good option. Alternatively, the Aetna HMO does tend to be one of our toughest options to move folks from into a high deductible. So it may be that is the case, unfortunately. Okay. So I think we covered a lot of this. Both the employee and the employer can make them on a pre-tax basis. Employee contributions can be done through salary reduction if they elect prior to the beginning of the year and it's written into your cafeteria plan document, or they can be an adjustment to income on the annual tax return. See, if we had just moved one slide, we would have had the answer for you. Employer contributions have to be comparable for like-situated employees, so there's discrimination rules in the health savings account. Because we are a single plan, we actually have a global cafeteria plan that for the entire Episcopal Church, to a degree, helps to take care of that comparability issue. Because like I said, one diocese may fund it at 100%, where another one may fund it at 50%. But we do ask that you all be mindful of the discrimination rule, so that you're not funding 100% for one person because you know that they're a high health risk and you want them to be in the plan, and you know somebody's 20 years younger and they're super healthy, and so you don't give them any HSA funds. IRS frowns on that. Okay, so this is the actual plan design. I'm not going to go through it in detail unless you'd like me to. It's kind of hard to read with the small details, and they're hard to remember. Okay, so pharmacy benefits, we did just want to touch on. Jeff will go into a little bit more detail about Express Scripts, but we did just want to touch on the difference. Because the one thing to really remember for folks, and what we really consider to be the biggest sticker shock item when folks enter a high deductible health plan, and that is that it's medical, pharmacy, behavioral, it's everything is all subject to that $2,700 deductible. So folks who go and get a prescription on January 5th and it costs $300 and they've always paid a $50 copay for it, that's when the rubber hits the road and they realize, wow, this is a different plan design. So we put this slide in the deck to make sure that you really can see, the difference between a traditional plan that's copay based now counts towards the out-of-pocket maximum, those co-pays, where they didn't before, and the high deductible health plan. This is one of our standard slides, so it shows our standard, our premium, and our high deductible health plan. If I recall correctly, the diocese has the standard level of pharma benefits, so this is just for a comparison, traditional plans to high deductible plans. Okay, Medicare secondary payer. This came up earlier, and I'm here to be the rule maker for a second. Medicare secondary payer is a rule that the government has that says if there is an employer who should be paying for benefits, the employer should be paying for the benefits, and Medicare pays secondary. Why do they do that? Because the government never wants to pay if they don't want to have to. No. More realistically, the government wants to preserve Medicare for as long as possible into the future as far as possible. And so if there is an employer benefit available to the employee, then that's who they consider to be primary. And if you have an employee who's over 65, then Medicare would be secondary. We do know across the church that a lot of groups are using retirees to come back to work. And so the one thing we ask you to do is to be very careful that you make sure if that retiree is really, if they walked in the door tomorrow, this is the analogy I use at the office and everyone laughs at me. If you had two employees who walked in the door and they both had a paper bag over their head, and you said this one works 40 hours a week and they earn X amount of money, and this one works 40 hours a week and they earn X amount of money, are they both eligible for active benefits? And you go, well, this one's 25, so they are, and this one's 67 and they're not. If they're active employees, they need to be offered active benefits. And we know that that is not always a happy message for folks to hear because folks are trying to use retirees to offset some of the expenses of an active employee. But we do need to stress that Medicare takes this rule very seriously, and where it can come back to sort of bite an employer if they don't follow the rules, you all complete voluntary data share information with the government all the time. Claims come through all the time. The systems actually do talk to one another, and so what happens is if you have that 67-year-old retiree who really should be on active benefits and you've got them on the Medicare supplement plan, you're going to get what's called a Medicare demand notice. If they went in and had, say a surgery, they had their knee replaced, it cost $40,000. The government's going to send you a letter that says, oh, hey, we paid $40,000 for this surgery, and we think that this is actually an active employee. Can you tell us if they are? And if they are, can you send us a check? And then you guys freak out. And we're able to help you with those demand notices when you get them, but we'd like to prevent them in the first place by getting folks enrolled in the right plans. So this is my soapbox at the office. I'm a risk manager. I was in property casualty for 10 years before I moved over to health benefits, so I'm always that risk person. Okay, so there is an exception to the rule, though. There's actually two exceptions to the rule. One, an employee is always free to reject employer coverage and go elsewhere, but they cannot be in an employer-sponsored plan. So your retiree who's back working actively could reject the plan. They could go get an AARP supplement or something. They'd have to pay for that themselves. You can't compensate them to do that. And they can't be in our Medicare supplement plan because we're an affiliation to the employer. The other thing is if the employer has fewer than 20 employees. And if the employer has fewer than 20 employees, then there's a thing called the small employer exception, and we have active health plans. Now this applies to anybody who's actively working and over 65, and in an employer with 20 or fewer. We now have with Anthem set up Medicare secondary payer coordinating plans. It's a relatively simple form that needs to get filled out by the employer and the employee. It comes to our office. We send it to the Medicare coordinator. They come back and tell us whether they agree or disagree. If they do, then the person gets to be in the comparable plan with Anthem that's relatively about 20% lower premium. And a big factor of that is that Medicare is paying primary for the inpatient hospital claims. So I don't think that the diocese today offers Medicare secondary payer plans, but if you do have small employers, 20 or fewer, separately incorporated, who have employees who are over 65, please, please, please reach out to Jeff so that we can get those plans available to you all.
When you say 20 or fewer employees, you mean like my church, where I'm the only full-time employee, then when I turn 65 this coming May, we can go to that and help him.
Yep. Are you separately incorporated, like you have your own employer identification number? You're not? Yeah.
Churches are incorporated individually or as dioceses? That's the question.
Most of the churches have their own, tax ID number.
Okay, I mean,
A couple missions don't.
Yes, then we want to talk to you between now and May. Yep.
I probably need to call y'all.
Yes, we do. Yeah, if you're going to continue to actively work, we want to talk to you because that has the potential to be a good option for you as well. Yes. So for an active employee who's over 65 on Medicare, working for a parish or an institution that has fewer than 20 employees, first we need to set up with the diocese that you all have the Medicare secondary payer options available to you. Then what happens is that the employee is going to fill out in a form and give it to their parish administrator, who's going to send it over to you guys. You guys are going to get it to our team. Our team's going to get it over to CMS. The coordinator's office is going to approve it, and then we're going to make sure that you're in that plan and getting that premium reduction for it. So it really is, the forms are available on cpg.org. It's a very easy 2-page form. There's an employee section, there's an employer certification on the back. It's a very simple form to fill out in addition to the regular enrollment form.
Again, I know this is very specific to me, that I'm 65 in May. So, but right now I'm only 64. So when I do open enrollment in October, do I pretend like I'm not turning 65?
Correct.
Okay.
Pretend like you're not turning 65, probably 3 months out, 90 days out. Make sure we connect. Yeah. Yes, we do. So we consider eligibility for a Medicare secondary payer plan to be a qualifying life event.
Okay.
Yep. We consider that a qualifying life event because we really see it as a win-win-win. It's a win for you where it helps reduce your costs. It's a win for your employer because it helps reduce their premium. And it's a win for the plan because it's driving costs out of the system. Okay. This is a sample of that plan design, so you'll pay attention to this one when they come out. All right, I'm going to turn it over to Jeff and have a drink of water.
You're not going to drink water?
I lied. I am going to drink water, but I do want to tee up pharmacy with one thing. So I talked earlier about the Church Benefits Association and the fact that we group purchase benefits together. We group purchase pharmacy benefits with 19 other denominations. I am the co-chair of that steering committee of the 19 denominations. Right now we're purchasing at 350,000 lives instead of just our 25, 30,000 lives. We do recognize that with Express Scripts comes some member dissatisfaction. We take that very seriously, and I'm on the phone with Express Scripts and with my coalition partners all the time. So if you've got issues, let me know. But when we look at that cost containment, what we've been able to do through group purchasing on the pharmacy benefits is a large chunk of that $69 million in savings that we've been able to put forth through the church. So we love working with our fellow denominations. They're a great group of people. We drive each other to push harder, negotiate harder, get more value for our members. So Jeff's going to talk about the benefits, but Express Scripts is in my shop, so if it's not working for you, come see me. Because we want it to be working for you.
That must be a rare case. Express Scripts is working for me. No, thanks, Andrea. Yeah, I'm going to go through the basics of the pharmacy benefits and what's offered in the Express Scripts relationship for your plans. The Express Scripts, as Andrea mentioned, is our plan partner for all prescription benefits across all of our plans, regardless of the vendor from which your plan comes from, whether it's Aetna or Cigna or others. When I speak about the pharmacy benefits, this is also confession time for me. I've been with CPG for nearly 10 years. Majority of that time, I'm relatively new to the IBAM side of this. Majority of that time I was with the publishing division that I prefaced earlier in the conversation today. And I didn't pay close attention to a few things that are folded into the benefits of the healthcare. I do my open enrollment election each year for myself and my family. And then things like prescription benefits, I didn't pay close enough attention. As we go through these slides, there's so many things that were revelations to me as I began to learn this business. Things you need to pay attention to, be proactive, work with your physicians to be sure that they understand the benefit or the pharmacy benefit plan that you have. So I mentioned Express Scripts is the provider for all plans. And now we'll look at the different Express Scripts pharmacy tiers. Of course, we all have heard of some of these or all of these. Generic prescriptions or generic drugs have the same active ingredients as the brand name replacement. And formulary, those are the brand name drugs that are covered by the plan. The non-formulary, those are brand name drugs that are not included in the formulary covered by Express Scripts. We'll talk a little bit more about that in a moment. One of the beautiful things about Express Scripts, and this is something that I mentioned, I have to confess, I was not interested in mail order prescription fulfillment. I don't have any maintenance drugs myself, my wife does, and when I first saw her start to receive mail order prescriptions, I said, I'm just used to going to Rite Aid and handing them the slip and then coming back 20 minutes to 3 hours later and getting that and taking it home. I just couldn't understand the concept of that. And it goes along with also paying bills online. I was one of the ones who just was really resistant to that for the longest time. I do now pay the majority of our bills online, and I'm accustomed to it. But the mail order for the maintenance drugs is really a fantastic service that I have found with Express Scripts. And some of the things here, again, the doctor can fax or order the prescription online. It's just a very nice component of that service. As we talked about the generic drugs, this is a great slide, generic or pay the difference. We're looking at drugs that you can accept the generic version of. For example, we have a drug with a brand name drug at $90 versus a generic at $30. Comes down to, won't do all the math. I'm sure you guys are tired of hearing numbers, but $70 net cost to the member in this example. Now the bottom statement here, this is important. If a generic medication cannot be used for a medical reason, call us to discuss. Now there are cases where the brand name is recommended by the physician for good reasons, and that those can be brought up. We'll talk about that again in a moment as we talk about step therapy. Right here, what is step therapy? Utilizes evidence-based medicine. Certain medications will be dispensed and covered only after others have been tried and failed. So the example of that, the generic would be prescribed first. If it's proven ineffective, then move to a formulary, which I mentioned are those brand name drugs that are covered under the Express Scripts plan. And if that's proven ineffective, then a movement to the non-formulary would be approved. But that does involve the step therapy process. Again, driving the business to generic is it's a cost savings for all. And if the generic drug is suitable for the condition, it's a win-win for all. But there are times when the brand name drug is required and needed for individuals' conditions. Sure. Oh yeah, question? Oh yeah, Janice. Pardon me? Non-formulary, let's jump back. Yeah, sure.
So
There we go. Oops, there we go.
I just want to make one clarification on the non-formulary. So there's a difference between excluded drugs and non-formulary. Non-formulary are the tier 3 drugs, so the most expensive drugs on the plan. They're those drugs that really are the not preferred drug, but that's the step before being an excluded drug. So they're the ones that really, there's therapeutic alternatives either at the generic level or at the brand level that are equally efficient, that cost less. So basically Express Scripts has this independent pharmacy and therapeutics committee, and they're the ones that 4 times a year decide where things sit on the formulary, and then once a year they decide what's excluded. They're really the ones that are not recommended, and that they cost more, and so they come with a higher copay as well. So I just wanted to clarify that.
So
Okay, so the question was, does that include medications that need to be compounded? Compounds are actually an exclusion on our plan. Compounding was a gigantic issue. So you remember earlier I talked about surplus and using surplus for good? Our compound spend in the course of about 9 months jumped from $200,000 to almost $1.6 million. And that is because compounding pharmacies figured out a way, due to a slight change in how compounds were calculated under the Affordable Care Act, that became a huge and gigantic revenue maker for compounding pharmacies. And so ESI, Express Scripts, and many of their clients, we were one of them, were very, very, very aggressive in excluding compounds on our plans. So 98% of the time, a compound is not necessary. 2% of the time it is. Most prevalently, where it is recommended is with children, in compounding certain drugs into liquids because kids can't take pills, so giving them those little like pink drops for like amoxicillin, it's the same kind of thing. That's the best avenue. So in cases of compounds, there is a clinical number at Express Scripts that can be called where the provider can make the case for the compound, and 2% of the time it will be allowed, 98% of the time it's going to be excluded. So, yes? So John asked a very good question for those of you who couldn't hear it. John goes to the big box store. In this case, you used Walmart, I think is the example. Costco's the other one that we hear. They have what they call loss leaders. So that's how they get you in the door. They get you in the door for a $4 prescription or a $2 prescription, usually a generic. We completely and absolutely encourage you to do that. And because it's being a good consumer. Why would you pay $10 for a prescription when you can pay $2 for a prescription? The one thing we would ask you to do is, if possible, to use your Medco card. It will reject because it's going under their $4 program. But what it will do is start to get that claim in your system, that drug in the system, so that it's part of your record. If you can't do it there, you can, if you're registered on the Express Scripts. Did I say Medco? That's how long I've been working with them, sorry. We were Medco before Express Scripts bought them. So we do want to have those drugs in your health record. So you can either use the card to affect that, or you could log it using the Express Scripts portal. Why do we want to have it in there? Because it could conflict with another medication that you have, depending upon what it is. Sometimes they have, things, blockbuster drugs, like, generic simvastatin, which that's the cholesterol one, right? So we want to make sure that we know that that's part of your record. One of the things that we do with Express Scripts is that we have a lot of data engines that share with one another, medical data, pharmacy data. One, we want to make sure you're not having any drug-drug interactions. Two, we want to make sure you don't have any omissions or gaps in care that could be affecting your therapy. You could be taking a drug, and if you're not taking it in combination with another drug, you might as well not be taking it. That's what we call waste in the system. You're taking a drug that's doing nothing. We'd rather have you spend more money, take that second drug, then they work together, it helps your health. And so we want that in your record from a safety, efficacy point of view, to just make sure that we know everything that's going on. Absolutely, we encourage you to be a good consumer. We wish we could have all the drugs be that cheap. Sometimes they have bigger purchasing power than we do. And that's how they get folks in the store, so.
Okay, so as I mentioned when I opened up the pharmacy conversation here, to be proactive, again, I read this and myself to understand, to talk to your doctor about your plan, review the Express Scripts formulary, what's covered and what's recommended, ask for generics when available, and also this is good advice here. Are the paper prescriptions for mail order for 90 days? Does your doctor know to request a 90-day supply? And did your doctor specify that generics may be dispensed? Sometimes they might write down the brand name of the drug, and that's what you could get. So they, need to specify that the generics can be dispensed, and that would, bring a savings to you. Okay, so a little behind the scenes of the Express Scripts management of the benefits. As we mentioned here, all the services that Express Scripts provides are not just the gatekeeper for the pharmacy or for the pharmaceuticals, but they also look at possible drug interactions. So these are professional pharmacists working within this network, and safety issues, the proper dosage, proper duration of using the drug, and so on. And they will also call your doctor directly with questions if they see something come across that doesn't look right. They'll make sure that they address that with the doctor to make sure that the members are safe and covered.